Welcome to this presentation on neurotransmitters. In the conventional approach, treatments that modify neurotransmission are guided by an algorithmic approach based on phenotypic expression. For instance, if an individual is experiencing major depression, then a series of first, second, and third-line pharmaceuticals are trialed. In this presentation, we will analyze the approach to neurotransmitter evaluation and treatment using advanced laboratory and diagnostic studies. This supports personalized treatment, potentially circumventing some of the problems we see in the conventional approach. The general approach to neurotransmitter modification includes empiric support, neurotransmitter evaluation, and further investigation. Empiric support is the phenotype-based evaluation and treatment I alluded to. This is typically the stopping place in conventional psychiatry and may include the incorporation of pharmaceuticals, nutraceuticals, psychotherapy, and/or lifestyle modification. In a step further, neurotransmitter evaluation allows us to look at neurotransmitter levels to personalize treatment recommendations. In the context of this presentation, the diagnostic testing we will use to explore this area is the neuroadrenal profile. In the territory of further investigation, we will look at underlying causes and contributing factors via general and specialized laboratory and diagnostic testing. Throughout this presentation, I'll highlight some areas worth investigating in more detail. I'll also highlight areas of organic acid testing relevant to neurotransmitter analysis, as you can derive similar guidance from this. It is outside the scope of this presentation to explore all these areas in detail, but I would like to provide some direction as to where you may want to look as far as additional investigation is concerned. Likewise, a full explication of organic acid testing is best reserved for a dedicated lecture. Empiric support is a good starting place to achieve some initial symptomatic improvement. While general laboratory test results may return in a few weeks, specialized testing tends to return in the window of 2 to 4 weeks. I generally recommend having a collaborative conversation with the patient to determine if an empiric option is preferred while awaiting laboratory and diagnostic studies. Here, the conventional toolkit may be utilized and pharmaceutical, psychotherapeutic, and lifestyle modifications may be considered as part of the plan of care to begin achieving some improvement in the patient's overall functional capacity. I would, however, like to focus just briefly on a few empiric nutraceutical options that we can consider. While there are several options that can be considered here, two have been well demonstrated to modify neurotransmission pretty effectively as empiric strategies. The first option is rhodiola. This is an adaptogenic herb that supports the HPA axis, optimizing cortisol levels and improving stress tolerance. It is generally recommended as the root extract with 4% rosivins and 1% salidroside. Rhodiola has a biphasic effect on monoamines, where low doses, shown here, increase neurotransmitter concentrations and high doses decrease neurotransmitter levels. This presents as a flexible empiric option that can be modified based on response. The second option is L-theanine. This is a green tea derivative and GABA agonist with neuroinhibitory and parasympathetic effects, bringing balance to GABA concentrations. It also brings balance to monoamines, whether high or low. It also antagonizes glutamate receptors, reducing glutamate levels. L-theanine increases glycine, reduces cortisol, and increases alpha wave activity in the brain, which is associated with a calm and focused presentation. It has synergistic effects with caffeine, helping to direct attention and reduce caffeine-associated restlessness. This can be started at 200 milligrams twice daily and titrated up in 200 milligram increments to 600 milligrams 3 times a day. This is generally well tolerated, but may not be advised in the context of severe depression because of its alpha wave activity. This may provoke already existing depression if severe. Neurotransmitter evaluation can be a valuable diagnostic tool to guide appropriate treatment. I often ask the question, if our goal with psychotropics is to modify neurotransmitter activity and concentrations, how are these synthesized in the first place? Is there a way to support the modification of neurotransmission outside of the utilization of pharmaceuticals? Here you'll find a visual representation of what years of exploration has revealed to me. In fact, this area is constantly developing and new discoveries are being made. Throughout most of the remainder of this presentation, we will explore neurotransmitters in more detail, with an emphasis on where we can support activity. Several cofactors and precursors are shown in this image in blue. Enzymes are in green. Additional steps that are unmeasured in the context of laboratory and diagnostic studies we will discuss today are in black. Components of the neuroadrenal profile are in amber, and components of organic acid testing are in pink. Neurotransmitter evaluation can help with executive or cognitive impairment, anxiety, depression, fatigue, insomnia, addiction, obsessions and compulsions, weight loss, cravings, poor impulse control, chronic pain, headaches, irritable bowel syndrome, and movement disorders. This is just a sample of areas where neurotransmitter evaluation may be helpful. Depending on the testing that will be considered, I've incorporated some considerations for test preparation here. For blood testing, which is mostly relevant in the territory of further investigation to explore some of the causes and contributing factors, fasting labs are best. Avoiding food after midnight and only drinking plain water, tea, or coffee in the morning, with completion of labs before 10 a.m. is recommended. While outside of the scope of this presentation, the neuroadrenal profile also examines the hypothalamic pituitary adrenal axis, providing a cortisol curve for analysis. Because of this, I provided some preparation considerations here surrounding the avoidance of steroids where appropriate before testing. It is also important to note that the first saliva collection should be done 30 minutes after awakening. For any urine collection, the first morning void should be collected before morning doses of any medications or supplements for accurate results. For testing, do not discontinue medically necessary daily prescription medications for testing. Test results can be considered in the context of these medications. It's ideal to minimize any medications or supplements that are non-essential for the most accurate results. For baseline endogenous levels, wait 5 half-lives after medication discontinuation before testing. In the context of neurotransmitter testing, avoid substances such as caffeine, nicotine, and alcohol for 24 hours, and avoid interfering foods for 48 hours. Several food items that boost serotonin and 𝐾𝐢𝐬𝐜 levels are listed here. I've highlighted bananas here because they tend to provide the most potent increases in neurotransmitters and carry the highest likelihood of yielding falsely elevated results. Now we will move into neurotransmitter evaluation. Here you'll see two images, one on the right showing the neuroadrenal profile, and one on the left showing Genova's metabolomics, which is an organic acid test. Please note that with the organic acid test image, this is only a snapshot of the specific area that addresses neurotransmitters. Along the several-page report, you'll find other markers that we will discuss here. This is also not the only organic acid test available. A full explication of organic acid testing is outside the scope of this presentation. In general, when neurotransmitters are too low, consider amino acid and precursor support. On the other hand, when neurotransmitters are too high, support enzyme cofactors that metabolize and convert neurotransmitters. You'll find a supplementary document with this presentation that summarizes the approach for clinical reference. Moving forward, a color code will be used to show what markers correspond with what test. Amber markers are on the neuroadrenal profile, and purple markers are on the organic acid test. Let's first look at dopamine. Dopamine is a catecholamine precursor to norepinephrine and epinephrine. Tyrosine is converted by tyrosine hydroxylase into L-DOPA. L-DOPA is converted into dopamine by aromatic amino acid decarboxylase. From here, dopamine has three options. First, dopamine can be converted into dihydroxyphenylacetic acid, or Dopac, by monoamine oxidase, or MAO, or hydrogen peroxide, H2O2, a reactive oxygen species. Second, dopamine can be converted into 3-methoxytyramine, or 3-MT, by catechol-O-methyltransferase, or COMT, which also converts Dopac to 3-MT, which is ultimately degraded into homovanillic acid, abbreviated HVA. Third, dopamine can be converted into norepinephrine by dopamine beta-hydroxylase. These steps and associated cofactors or precursors will be important as we move forward with our evaluation. Recall that I mentioned for low neurotransmitters, consider amino acids and precursor support. The amino acid required for the synthesis of dopamine is tyrosine, which can be supplemented in the form of N-acetyl-L-tyrosine. Note that tyrosine can be evaluated on organic acid testing, along with other proteins. Also, some of the precursors can be evaluated by general labs, and others are best tested by organic acid testing. In the best-case scenario, precursor support is guided by testing, but this may not always be the most cost-effective for the patient. If this is the case, general multivitamin preparations that cover most of these precursors is best. One that is most specific to dopamine is Dopa Plus. This also has low-dose L-theanine, rhodiola, and mucuna pruriens, and can be used to wean off dopaminergic agents. You'll notice a recurrent theme with the use of a few of the empiric options such as rhodiola and L-theanine. Remember that lower doses of rhodiola support low neurotransmitters. An option unique to supporting dopamine is mucuna pruriens, which contains L-DOPA. Pharmaceutical options for low dopamine include bupropion, stimulants, brexpiprazole, aripiprazole, ropinirole, pramipexole, levodopa, and ketamine. A few non-pharmacologic options include massage and meditation. For low dopamine or HVA, consider the following areas for root cause evaluation and treatment. Evaluate protein levels, which can be explored via organic acid testing, looking for low amino acids, especially tyrosine. Consider the incorporation of an amino acid blend if tyrosine is not the only deficiency. Next, consider the gut-brain axis to rule out malabsorption and maldigestion. Some of this can be identified on organic acid testing, but specialized stool analysis will provide more detail. The same should be considered in the context of micronutrient deficiency, examining for underlying causes. By extension, evaluate dietary intake and nutritional status in more detail. Dysmethylation is a common underlying cause and can be explored through a homocysteine level, organic acid markers, and genetic testing. Support typically includes methylated B complex, but other considerations may be revealed by further testing. Adrenal dysfunction, especially hypoadrenalism, is a potential cause of low dopamine levels and is best evaluated by cortisol curve testing. General support typically includes micronutrients and adaptogenic herbs. Rhodiola is one of these. Finally, there are some agents that will deplete dopamine levels that should be considered in the context of the individual patient. Dihydroxyphenylacetic acid, or Dopac, is evaluated through organic acid testing and typically reflects low dopamine. When low, consider the following. Explore for phenylalanine and tyrosine deficiencies, both necessary amino acids. Support BH4 and/or vitamin B6 deficiency. Also consider MAOI use or MAO genetic polymorphism and aldehyde dehydrogenase impairment, which impedes conversion to Dopac. These should be considered in addition to factors that reduce dopamine. For high dopamine, provide cofactors to support enzymatic activity, specifically MAO and COMT. You can also utilize L-theanine and high-dose rhodiola to reduce dopamine. Antipsychotics and buspirone to some degree will lower dopamine. Finally, consider supporting the conversion of dopamine to norepinephrine via dopamine beta hydroxylase if necessary. Again, several of these factors can be combined in general support and evaluated by laboratory and diagnostic testing, including the organic acid test. For a high dopamine or HVA, consider the following areas in your root cause evaluation. Hyperadrenalism can be evaluated through cortisol curve testing. For cofactor and precursor deficiency, examine underlying causes by looking at the gut and dietary intake, ruling out malabsorption and maldigestion. If the HVA is 2 times the upper limit of normal, conduct a 24-hour urine metanephrine to rule out pheochromocytoma. Several interfering agents are listed here that could be considered in the context of dopamine or HVA elevations. An elevated Dopac found on organic acid testing may be reflective of high dopamine and low dopamine beta hydroxylase activity. The following may be considered in a root cause evaluation. First, ensure that oxidative stress is well managed. This can be evaluated through organic acid testing, a GGT, or glutathione levels. Treatment consists of CoQ10 and glutathione supplementation. Dysbiosis, specifically overgrowth of Clostridia species, and mold exposure as evidenced by an elevated fusaric acid, are key considerations. Markers for both of these are included in some organic acid testing. Cofactor deficiencies, specifically vitamin C, copper, B3, and SAM-E, should be evaluated and treated, and, as before, further investigation may include stool analysis. Some noteworthy interfering agents include disulfiram and aspartame. Aspartame can be evaluated on organic acid testing via aspartic acid. Finally, malic acid deficiency contributes to elevated Dopac, which is also potentially implicated in fibromyalgia. This can be evaluated via organic acid testing, and supplementation can be considered. The HVA-Dopac ratio clarifies the relationship between HVA and Dopac. A decreased ratio indicates low conversion of Dopac to HVA, often due to SAM-E deficiency or a 𝐘𝐲 or MTHFR genetic abnormality. An increased ratio indicates high conversion of Dopac to HVA, likely due to high SAM-E, L-methylfolate, or B12 supplementation. These nutrients subsequently increase endogenous SAM-E production and are commonly implicated in the treatment of MTHFR polymorphism. Next, let's turn our attention to norepinephrine and epinephrine. These are both released from the adrenal medulla in response to stress. They regulate the sympathetic nervous system, attention and arousal, as well as heart rate and glycemic control. Dopamine is converted by dopamine beta hydroxylase into norepinephrine. From there, norepinephrine has two options. Norepinephrine can convert into normetanephrine under the influence of 𝐘𝐲-𝐬-methyltransferase, or �CoMT. Normetanephrine can then convert into vanilla mandelic acid, or VMA, under the influence of monoamine oxidase, or MAO. Alternatively, norepinephrine can convert into epinephrine under the influence of phenylethanolamine, or PNMT. Epinephrine is then converted into metanephrine by �CoMT. Finally, metanephrine is converted into VMA by MAO. As with dopamine, you'll see some of the various cofactors and precursors listed here. Note that because norepinephrine and epinephrine are derivatives of dopamine, appropriate dopamine support should be simultaneously considered. In the treatment of low norepinephrine and epinephrine, and subsequently a low VMA level, aside from rhodiola and L-theanine, we could consider stimulants, norepinephrine reuptake inhibitors such as atomoxetine or viloxazine, serotonin norepinephrine reuptake inhibitors, MAOIs, and mucuna pruriens. Amino acid and precursor support is the same as with dopamine because of the overlap in the pathway. In a root cause evaluation, consider the following areas. For precursor and amino acid deficiency, consider gut and dietary evaluation. Conduct a workup for adrenal dysfunction, especially looking for hypoadrenalism. Explore genetic abnormalities such as MAO polymorphism. Finally, rule out the presence of any offending pharmaceutical or nutraceutical option. For high norepinephrine and epinephrine, in addition to L-theanine and high-dose rhodiola, you could consider meditation, norepinephrine antagonists, alpha-1 adrenergic receptor blockers, beta blockers, omega-3 fatty acids, melatonin, chamomile, lemon balm, 𝐃𝐲, and MAOIs. Additionally, it may be helpful to consider supporting downward conversion via PNMT with cortisol and SAMe support. Cofactors for enzyme support should be considered, especially for MAO and COMT. In a root cause examination, consider a workup for adrenal dysfunction, as these findings are suggestive of stress and sympathetic nervous system hyperactivity. If the VMA is 2 times the upper limit of normal, consider a 24-hour urine metanephrine to rule out pheochromocytoma. Some agents that may contribute to high norepinephrine and epinephrine include L-DOPA, tyrosine, phenylalanine, norepinephrine reuptake inhibitors, psychostimulants, serotonergic agents, and aluminum toxicity. The norepinephrine to epinephrine ratio examines the conversion between norepinephrine and epinephrine. Note that this process is cortisol dependent. A decreased ratio provides no clear clinical direction except possibly examine the HPA axis looking for impaired activity. A high ratio, on the other hand, can be supported with SAMe and HPA axis support, which can be fine-tuned by testing a cortisol curve, which, as we discussed before, is incorporated in the neuroadrenal profile. This finding tends to correspond with chronic stress. The organic acid equivalent to the norepinephrine-epinephrine ratio is the HVA-VMA ratio. Similarly, an elevated ratio is more clinically significant. In addition to considerations on the previous slide, when the HVA-VMA ratio is increased, consider the following. First, there may be poor conversion of dopamine to norepinephrine, indicating a precursor deficiency. As previously discussed, extend this exploration by incorporating gut and dietary evaluation. Second, there may be poor conversion of norepinephrine to VMA, in which case there may be poor COMT and MAO functioning, necessitating support as described on previous slides, and possibly genetic testing. Now we'll turn our attention to serotonin. 80 to 90% of serotonin is synthesized in the gut, and the rest is in platelets and the central nervous system. This is linked to the rationale behind the capacity of serotonergic agents to contribute to platelet abnormalities and the associated bleeding risk. Tryptophan is converted into 5-hydroxytryptophan, or 5-HTP, by tryptophan hydroxylase. 5-HTP is then converted into serotonin, or 5-HT, under the influence of AAA-DC. From here, serotonin may enter 2 potential pathways. Serotonin can be converted into the metabolic byproduct 5-hydroxyindoleacetic acid, or 5-HIAA, by monoamine oxidase. Alternatively, serotonin can be converted into acetylserotonin by N-acetyltransferase. This is then converted by hydroxyindole O-methyltransferase, or COMT, into melatonin. For low serotonin, outside of rhodiola and L-theanine, some other agents that increase serotonin include St. John's wort, massage, meditation, SSRIs, SNRIs, TCAs, MAOIs, SGAs, and serotonergic psychedelics. The amino acid to consider for low serotonin is tryptophan. However, as we will discuss on a future slide, tryptophan can be shunted away from serotonin synthesis under the influence of inflammation. Therefore, ensure that the high sensitivity C-reactive protein is less than 1.0 And if you've conducted organic acid testing, ensure that the 𝐘𝐢𝐬𝐿 markers are balanced. Note that estrogen dominance and hypercortisolemia also shunt tryptophan away from serotonin metabolism. As an alternative, supplementing with 5-HTP bypasses this metabolic step and may be more appropriate. Some key precursors include vitamin D, iron, P5P, and precursors for BH4 support. For convenience, Sero Plus combines many of these prerequisites for serotonin metabolism. In a root cause evaluation for low serotonin, consider examining the gut-brain axis to rule out impaired gastrointestinal motility and methane-producing small intestinal bacterial overgrowth or SIBO. This should especially be considered in the context of evident amino acid and precursor deficiencies. As I alluded to, tryptophan may be shunted away from serotonin metabolism and into the 𝐘𝐢𝐿 pathway under the influence of inflammation, high cortisol, and high estrone. This will be discussed in more detail in a future slide. Genetic conditions such as PKU and Hartnup disease can lower serotonin. Finally, low tryptophan intake, mastocytosis, and alcohol use impair serotonin synthesis. In addition to L-theanine and high-dose rhodiola, benzodiazepines and cyproheptadine may reduce serotonin levels. Cofactors for enzyme support centers around the support of MAO, and the inclusion of SAMe may be helpful. In a root cause evaluation of high serotonin, the following should be considered. In the context of cofactor deficiency, explore the gut-brain axis as well as diet, looking especially for signs of hydrogen or mixed SIBO, celiac sprue, and Whipple's disease. Evaluate for the presence of agents that increase serotonin. In addition to those previously mentioned, note that acetaminophen and guanfacine, especially chronic use, may increase serotonin levels. In the diet, explore for the presence of hydroxyindoles-containing foods. Several plant-based options increase levels and may need to be modified. Lastly, neoplasms such as oat cell carcinoma, carcinoid tumors, and carcinoid lung adenomas have been demonstrated to increase serotonin levels. Melatonin supplementation has been shown to increase serotonin levels. Melatonin supports cytochrome P450 2D catalyzed serotonin synthesis from 5-methoxytryptamine in the brain, which closes the serotonin-melatonin-serotonin biochemical cycle. Aside from melatonin supplementation, studies have shown that melatonin levels are higher in the evening following meditation. Now let's turn our attention to the 𝐘𝐢𝐿 pathway. These markers are only evaluated on organic acid testing, but reveal a shunting process that may occur in the context of estrogen dominance, HPA axis hyperactivity, and inflammation. Under the influence of this process, tryptophan is shunted from the methoxyindoles pathway into the 𝐘𝐢𝐿 pathway. Instead of converting into serotonin and ultimately melatonin, tryptophan is converted into 𝐘𝐢𝐿. Here, 𝐘𝐢𝐿 is broken down into kynureninic acid and quinolinic acid. The subsequent mixed antagonist and agonist activity interferes with NMDA receptors, leading to neurotoxicity, low brain-derived neurotrophic factor or BDNF, and reduced neuroplasticity and synaptogenesis in the presence of glutamate. This also contributes to a reduction in BH4, increased dopamine, norepinephrine, and serotonin transporter activity, with subsequent decreases in neurotransmitter availability, and impaired excitatory amino acid transporter, or 𝐬𝐴T2 activity, which leads to a further increase in glutamate. Furthermore, there's a reduction in NAD and an associated increase in free radical generation, contributing to oxidative stress. On the following slides, we'll explore some of these nuances of this vicious cycle. Quinolinic acid binds to NMDA and alpha-7 nicotinic acetylcholine receptors, upregulating activity. When quinolinic acid is higher than kynurenic acid, it's important to explore for signs of neuroinflammation, toxic exposure, hypercortisolemia, and estrogen dominance. On the other hand, lower levels of quinolinic acid are not typically clinically concerning. Some of the specific consideration in the context of elevated quinolinic acid include treatment for chronic inflammatory or autoimmune diseases. A detailed analysis of these strategies are outside the scope of this presentation, but curcumin and specialized pro-resolving mediators, or SPMs, are some common strategies to combat this. If there are signs of neurodegeneration, incorporate a full investigation and appropriate treatment. An advanced analysis of sex hormones will reveal any evidence of estrogen dominance and guide appropriate interventions. The HPA axis should be examined looking at the cortisol curve to consider appropriate treatment and support. Examine ecologies and treat appropriately for any signs of a dysbiotic environment or potential biofilm. Phthalate exposure can be investigated and appropriate detoxification support may be initiated. This may coincidentally include curcumin, as it has been shown to upregulate phase 2 liver detoxification. In the setting of high tryptophan supplementation, consider reduction or elimination and utilizing 5-HTP as an alternative. For general support in the context of a high quinolinic acid, consider magnesium glycinate to offset the activity of glutamate and glycine to bring balance to the glutamate and GABA relationship. Kynurenic acid is neuroprotective, but elevated levels suggest abnormal tryptophan metabolism and neurotoxicity, indicating issues with glutamatergic neurotransmission and associated excitotoxicity and coinciding neuroinflammatory processes. Kynurenic acid binds NMDA and alpha-7 nicotinic acetylcholine receptors, downregulating activity. A low kynurenic acid is debatable, with some arguing that no issues arise out of this. However, some have associated a low kynurenic acid with depression, bipolarity, Alzheimer's disease, and headaches. Clinical direction here is unclear. In the context of a high kynurenic acid, consider the following. First, kynurenine is converted into hydroxyanthanolate, catalyzed by kynureninase, which needs B6 as a cofactor. Therefore, P5P supplementation is critical when low levels are identified. Discontinue any tryptophan supplementation, favoring 5-HTP. The gut should be worked up looking for signs of infection or dysbiosis with implementation of appropriate strategies. Inflammation and autoimmune disease should be ruled out as a contributing factor and appropriately treated if present. As before, the HPA and HPG axis may need to be evaluated and treated. Finally, 𝐘𝐢𝐬𝐬 deficiency can occur in the context of genetic polymorphism and has been implicated in MS exacerbations. Glutamate is the major excitatory neurotransmitter. Low levels of glutamate can be supported by incorporating the amino acid glutamine. For high glutamate, consider L-theanine, taurine, N-acetylcysteine, magnesium, and cofactor support. Gamma-aminobutyric acid, or GABA, is a major inhibitory neurotransmitter. It predominantly interacts with GABA-A receptors to modify activity. In the context of low GABA, consider L-theanine, lavender, GABA, taurine, glutamine, cofactor support via P5P, meditation, antiepileptics, benzodiazepines, baclofen, and/or topiramate. For a high GABA, consider L-theanine. Note that an elevation in GABA may be compensatory in the context of excitatory neurotransmitter elevations. Treat any gut dysbiosis, as this is a common source of high GABA. Histamine is evaluated on the neuroadrenal profile, but it's important to note that histamine is volatile, and oftentimes testing can be inaccurate. While histamine is not evaluated on organic acid testing, histidine, the amino acid precursor, is. From this, you may be able to derive an idea of histamine activity. If the histamine level is low, consider histidine and cofactor support. In the context of an elevated histamine level, consider avoiding histamine-rich foods, diamine oxidase, anti-inflammatory compounds, zinc supplementation, and cofactor support. A full discussion of histamine activity and biochemistry is outside the scope of this presentation, but it is important to note here that histamine derangements almost always reflect problems with methylation. So evaluating methylation via genetics, organic acid testing, or other specialized testing may be an important consideration. In the context of low glycine, consider supplementation with glycine, L-theanine, bone broth, and cofactor support. If the glycine level is high, consider alpha-lipoic acid, which is a cofactor for the glycine cleavage system that degrades glycine into pyruvate, as well as appropriate cofactor support. The last one we'll discuss is phenethylamine, or PEA. This is a derivative of phenylalanine that has stimulating and excitatory properties. This tends to increase alongside dopamine. Studies have implicated a low PEA in ADHD, depression, bipolarity, autism, and Parkinson's disease. When the PEA is low, consider providing phenylalanine, P5P, PEA, probiotics, inhibiting MAO-B, and exercise. Note that phenylalanine requires conversion into PEA, and it may be more effective to recommend PEA directly. For a high PEA, which is associated with anxiety, nervousness, paranoia, aggression, increased alertness, and decreased appetite, consider dietary adjustment to reduce protein and fermented foods, stress support, probiotics, and support for MAO metabolism. This brings us to the end of the neurotransmitter evaluation. Now let's turn our attention to the final section, further investigation. Several influences by other systems were discussed alongside each neurotransmitter marker and metabolite. Further investigation carries us into an exploration of root causes and contributing factors. This is best captured by the acronym HPA-GGTIME. which stands for the hypothalamic pituitary adrenal and gonadal axis, the gut-brain axis, thyroid axis, immune axis, micronutrients, and epigenetics. Please note that a full explication of each system is outside the scope of this presentation. We will emphasize only key associations to nurture your investigative efforts. Let's first start with the HPA axis. Stress is the common factor between the HPA axis and neurotransmitters. An elevated norepinephrine-epinephrine ratio can be indicative of chronic stress. Serotonin is involved in the function of the HPA axis as it facilitates the release of ACTH from the pituitary, which then promotes the release of DHEA and cortisol. Low serotonin, therefore, can contribute to depleted cortisol. Stress inhibits the conversion of tryptophan to 5-HTP, the rate-limiting step in the production of serotonin and, ultimately, melatonin. Tryptophan is instead converted into quinolinic and kynureninic acid. A way to circumvent this while optimizing the HPA axis is to supplement with 5-HTP instead of tryptophan. It is suggested that glucocorticoid regulation may be one of the mechanisms of action for some antidepressants. In the territory of the HPG axis, estrogen dominance interferes with serotonin synthesis, particularly estrone. This causes shunting of tryptophan into the kynurenine pathway, reducing serotonin and melatonin availability. Additionally, estrogen receptor activity has been linked to psychiatric symptoms, especially anxiety. Gonadotrophins have also been demonstrated to interact with dopamine and serotonin receptor activity with a variable influence on neurotransmitter activity. Optimized gut-brain axis functioning is essential for the intake of cofactors and amino acids required for synthesizing neurotransmitters. Therefore, ensuring appropriate digestion and absorption by evaluating digestive enzymes and hydrochloric acid may be appropriate considerations. Also, the enteric nervous system, or ENS, mirrors the activity of the central nervous system. The structural similarities between the intestinal and blood-brain barrier also solidify this connection. Therefore, considering the integrity of the intestinal barrier and potential disrupting factors is important. This is closely linked to the immune-brain axis. Address the gut ecology and tolerance of food products. Methylation is considered here as an extension of the gut-brain axis, as it's a phase 2 detoxification process. But note that there are key epigenetic correlates, such as MTHFR, COMT, etc., related to this. 5-MTHF is a critical cofactor for neurotransmitter synthesis. 5-MTHF combines with BH2, biopterin, via the MTHFR enzyme to produce tetrahydrobiopterin, or BH4, which is required to synthesize monoamines, serotonin, dopamine, norepinephrine, and epinephrine. Homocysteine to methionine conversion requires methylcobalamin and 5-MTHF. Methionine is then converted to SAMe, the methyl donor for all monoamine neurotransmitters. MTHFR genetic polymorphisms cause difficulty processing dietary folate, often leading to suboptimal levels of monoamines and glycine. Thyroid disease contributes to depression, anxiety, irritability, executive impairment, fatigue, and weakness. Optimal thyroid functioning can be evaluated through a thyroid hormone panel, and pharmaceutical and nutraceutical interventions can be considered to optimize functioning. Several cofactor requirements for thyroid hormone are shared with neurotransmitters. Inflammation is a key factor in neurotransmitter balance. Sources of inflammation include obesity, a sedentary lifestyle, disordered sleep, adverse childhood events, psychological and physical trauma, medical illness, infection, and medical treatments. Consequently, there's increased glutamatergic activity with subsequent reduction in brain-derived neurotrophic factor, increased presynaptic uptake of monoamines, activation of indoleamine dioxygenase, which breaks down tryptophan, and decreased cofactors for the enzymes that synthesize monoamines. BDNF normally enhances the expression of tryptophan hydroxylase, the rate-limiting step in serotonin synthesis. The functional presentation of this is psychological illness. Several micronutrients have been discussed throughout this presentation as cofactors and precursors. Just a few additional notes. Vitamin D activates the genetic expression of the enzymes tyrosine and tryptophan hydroxylase, which are rate-limiting steps in producing catecholamines and serotonin. The vitamin D level should be optimized to greater than 60. Iron is a cofactor for both tyrosine and tryptophan hydroxylase enzymes as well. This should be the ferritin should be optimized to greater than 40. Several genes have been implicated in neurotransmitter activity. Some of these include MTHFR, 𝐘𝐲, DAO, MAO, and HHNT, among others. Advanced genetic testing can illuminate genetic polymorphisms and guide appropriate interventions for epigenetic modification. Here I have some baseline labs listed depending on the direction that you're taking. One set of labs to consider in lieu of organic acid testing, and another set of labs to be paired with organic acid testing. In addition to what we've discussed, organic acid testing will evaluate gut, neurotransmission, oxidative stress, mitochondrial functioning, detoxification status, methylation, amino acids, and micronutrient status. Neurotransmitter testing can be repeated in 3 to 6 months after initial testing and sooner if significant changes occur in symptoms. This is best done in conjunction with spot testing for associated cofactor support. Alternatively, if you are emphasizing organic acid testing, the same is true and the test can be repeated in 3 to 6 months. Here are a few slides with references. Thank you for listening to this presentation. You'll find the notes and clinical reference materials in the module.